So this lecture is going to cover mood disorders. And when we're talking about mood disorders, we're talking about the depressive disorders as well as bipolar disorders. So there's going to be some overlap in this between the module for this week and for next week. But I'm going to cover a little bit of information from both weeks. So when we talk about a mood disorder, what is a mood disorder? It's anything that is a disturbance of the affect that deviates from the norm. So when we talk about affect, what's the difference between affect and mood? Okay, a mood is what a client reports to you, and affect is what you observe in them. So when you can observe something that deviates from the norm. Okay, and these deviations can be physical symptoms, they can be behavioral symptoms, or cognitive features. Okay, and the disturbance is not it's not something that's very specified, but that can exist along a continuum, and it can be anywhere from too low, so it's going to be on the depressive end of things, or too high, which would be on the manic end of things. And they can cycle from low to high. So when we look at what causes mood disorders, well, there's several different theories about that. So when we look at the biological theory um, has some research behind it that supports that there's a genetic contribution to this. So that we see that there's a history of running in families, a family history of this. There's even a family history of how individuals, family members respond to medication. So if you have family members that have had positive responses to a certain type of medication, it's likely that other families would respond well to that same type of medication as well. So, and when you're looking at this biological theory, it's looking at the imbalance of neurotransmitters. Typically, with mood disorders, you're talking about norepinephrine and serotonin. And then you're also looking at sleep disturbances that can cause a mood disorder. And this is kind of a chicken or an egg type of thing, of that we know that with depression, that there is a sleep disturbance, but we also know that not just depression, with a mood disturbance, um, but that also um, a mood disturbance can cause sleep disturbance, but sleep disturbance can cause a mood disturbance as well. There's something that's called ICU psychosis, and it's when people are in ICU for a long time for a medical issue, and that when their sleep patterns are disrupted, they actually develop psychosis. And once they get out of ICU and they return to a normal sleep pattern and sleep rhythm, that the psychosis completely dissipates. So this is one of the things sometimes that you don't know which came first. You know, the were they depressed first, or the mood disturbance was there first, or did they start having problems with sleep? So that's something to be sure that you're investigating. A psychological theory in looking at mood disorders can look at early losses, um, anger issues, that unresolved psychological issues can cause a mood disturbance. Behavioral issues that when we don't receive positive reinforcement for our the actions that we are taking, that our efforts to receive recognition, that can cause us to have a mood disturbance. A learned helplessness can cause it. Cognitive problems, that when we start having errors in the way that we think, faulty assumptions, illogical thinking, when we have negative beliefs about ourselves, that can cause a mood disorder. If you look at it from the humanistic and existential standpoint, that if we don't achieve our potential, if we don't accept responsibility for our choices, or we're not accepted, then that can cause a disturbance in mood. Or that psychosocial stressors, if you're looking at it from a sociocultural standpoint, that if you're just have a lot of psychosocial stressors, that can cause a mood disturbance. So some of these things can definitely be proven. Biological theory has more research that can support it. Some of these other things are a little bit more difficult to prove. Doesn't mean that they're not true, but that they're a little bit more difficult to demonstrate that a true cause and effect. So there's different types of depression. There's endogenous or autonomous depression, and those are the ones that have a biological cause. Those are the ones that are more responsive to an antidepressant. A reactive depression is less severe, and those are the ones that are more likely to be psychosocial or environmentally responsive. And so those would be the ones that would probably be more responsive to a counseling intervention. Guilt or self-reproach would be related to some of those internal feelings of guilt and shame. Those would be more likely to be responsive to a counseling intervention. Those psychotic symptoms, those may be related to, like we said, having to do with some physical things that are going on, or it can be some psychological stuff, feelings of self-worth that have reached a delusional proportion. It can be that you just reached that a really high level of condemning or critical level that you have reached auditory hallucination, or a paranoid level. Sometimes when depression reaches a really severe level, you can have depression with psychotic features, that it just gets that severe, and that people start having hallucinations or delusions that go along with it. So when you look at the range of symptoms, like I said, they're on a continuum. So you can see that it can just be somebody who's experiencing sadness to complete hopelessness. Anhedonia is a complete loss of interest in anything that you used to enjoy or that you would find pleasure in. That kind of having a lack of energy to complete lethargy. Having just a little bit slow, retarded pace of speech to complete catatonia. Sleep disturbance to severe insomnia. The insomnia is what can reach the point sometimes where psychosis is what results in that. Somatic complaints, those are physical complaints to really complex physical ailments that you don't seem to be able to find a true cause for. Doesn't mean they don't exist, but you can't find a medical cause for. A lot of those are stress-related illnesses, things like migraines, a lot of gastrointestinal issues. That it's the psychological problems that are resulting in physical problems. Being a little bit agitated to really high levels of restlessness, losing interest in sexual activity, to decrease libido. You can have a loss of interest in your work, your usual activities, to being completely unable to function, not able to get up, not able to go to work, not able to complete daily activities of daily living. People who are no longer bathing, not able to take care of your daily responsibilities of taking care of your house or your children. I had a close friend who lost 40 pounds and basically was laying on the couch every day before and just completely non-functional before anybody realized that she was depressed and that that was what was going on. And hers was a postpartum onset after the birth of her fourth child, and people just kind of thought, she just had her fourth child, and she's tired. 4 kids, or it's a lot on you, but it got really, really severe before anybody realized how bad it was. Difficulty concentrating and paying attention to things, to really slow thinking and the inability to really think through things. Having kind of generalized anxiety to complete panic. And I know we think about that with anxiety, but that can go along with depression as well. Having, feeling badly about yourself to really complete self-degradation. Feelings of powerlessness to lack of control. Having some negative thinking to complete and total hopelessness. So again, this is that range of symptoms. It's on that continuum. You can have people who kind of have some kind of vague suicidal ideation of, maybe things would be better off if I wasn't here, I wish I didn't have to deal with this stuff, to a suicide attempt. General vegetative symptoms that, again, laying on the couch all day long, not eating, not bathing. In working in the hospital, we had patients that we would have to go in and get them out of bed, put them in the shower, make them get dressed, make them eat. That's how decompensated they were from their depressive symptoms. In some people, you'll see some of the physical changes as changes in their posture, changes in speech. Their speech becomes very flat. That you don't see any changes in inflection in what they're, no rise and fall to their normal speech patterns. Very flat affect, no facial expressions. Their manner of dress may become very drab. They may become disheveled. Unclean, personal hygiene may be a problem. So you're looking for some of those changes in things from what they normally look like. So when we look at criteria related to mood, okay, you're looking at a period of time in which the mood deviates from the norm. Okay, so you're looking at a mood episode, and typically that mood episode has to be a period of at least 2 weeks. Everybody has a period of time in which their mood varies. We all have periods of time where we may feel a little melancholy or we may feel sad. But when that period becomes kind of pervasive all day, most of every day, for a period of at least 2 weeks. Okay, so then you begin looking for what we call the building blocks for constructing this diagnosis. Okay, and to look at some type of mood disorder diagnosis, whether it be a depressive disorder or a bipolar disorder, you're looking for episodes. And there are 4 types of episodes. There's a major depressive episode, there's a manic episode, there's a mixed episode, and a mixed episode is showing the evidence of a major depressive episode as well as a manic episode, and then a hypomanic episode. And a hypomanic episode is that you're showing evidence of mania, just not full-blown mania. It's not at the extreme level of mania, but it is elevated more than a normal mood. So this is some of the criteria that you're looking for a major depressive episode. So that's what we're going to be looking at this week. So you're looking at 5 or more of these descriptors: depressed mood most of the day, every day, loss of interest or appetite in activities, change in appetite or weight, sleep disturbance, fatigue or loss of energy, feelings of worthlessness, guilt or hopelessness, psychomotor retardation or agitation, difficulty concentrating, and suicidal ideation. Okay, now one of the things that you can also see, not just necessarily depressed mood, but you can also see this irritation and agitation. You don't meet the criteria for a mixed episode, that this is causing a significant level of distress or impairment, that whatever your symptoms are, that they're not related to a general medical condition or substance abuse, or some, not necessarily just substance abuse, but some type of medication. So this is what we call an exclusionary criteria. Okay, that we're ruling out something else that could be causing this. I need to take this out. Not related to bereavement is old criteria. Used to be that we would say that it is not related to bereavement. And I just want to make a statement about that, because although the DSM criteria says that it still can be related to bereavement, if somebody has just lost someone, I think we have to be really, really careful making a diagnosis if somebody has just experienced some type of major loss. You know, there's a purpose in your life for grief. Grief is a normal process that we go through, and there's a benefit to grief. It's something that we need to experience, and that when we're too quick to step in and try to intervene and don't let people go through the normal grieving process, I think that's when we end up with people who have complicated grief issues that 3 years down the road, they still haven't totally resolved their feelings of grief. I've known several people who've, lost a husband or lost a family member, and especially their primary care physician is real quick to want to give them medication to help them feel better. And I don't think that that's a good thing. 6 months down the road, if you're still not functioning real well, maybe then. But in those first 6 months, you're not going to feel well. Now, if you're not able to get up and go to work, that's one thing. If you're not able to take care of your kids, that's another thing. But if you're still feeling pretty sad, and that's kind of how we should be feeling at that time after a major loss. So I think we have to stop and think about what's a normal grief response, and how should somebody be functioning at that time, and are they able to take care of what they need to be doing, and how should we be supporting them through that time, and be careful about jumping too quickly to medication, and trying to medicate away those feelings. So I think this little chart here is really helpful in starting that differential diagnosis process. So if we have only a major depressive episode, nothing else but a major depressive episode, then we're looking at major depressive disorder. Okay? If we're looking at major depressive and manic or mixed, you see our little arrows here, or hypomanic, then we've got bipolar 1. And we'll look more at this next week. if we're looking at major depressive and hypomanic than bipolar 2. So these charts help us to look at how that decision is made in there. So if there's no mania whatsoever at all, then we're looking at a major depressive episode. That it's and they're using the term unipolar depression. Personally, I hate the term. The term is not in the DSM. You'll see it in your book. Unipolar depression is major depression. I don't understand. If it's only one pole, it's major depression, major depressive disorder. And that's how it is listed in the DSM. So that's just a little bit of information there about mood disorders. Read the information in your textbook. That will help you more. And then I want you to watch the video on evidence-based treatment planning. And then we'll move forward in looking at your assignments for this module.